The Limi Children's Hospital is a multi-specialty children's hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
So, a very good afternoon once again, my trainers, teachers, senior colleagues, and colleagues. So, I'm Dr. Nwala Gabriel, a consultant pediatrician with Limi Children's Hospital, and with me,
Dr. Faiza is Aliyu, Pediatric Medical Officer.
Okay, so in the next couple of minutes, we'll be having discussions on recalcitrant seizures. So this webinar series is coming from the stables of Limi group. It's a multi-specialty facility that has a number of expressions. So the presentation is coming to you from the Limi Children's Hospital. That's the specialty for pediatrics, neonatology, adolescent medicine, pediatric cardiology, and neurology. Located in Wuse, Demolade Tukumbo, recent in Wuse 2. So what pioneered this expression was the desire to draw rich healthcare experience from different areas of pediatrics subspecialty, discourage medical tourism, or most of the things people travel out to go and get in terms of healthcare are things that can be offered right here in Nigeria, and that is what we offer. And this expression was commissioned in 2017 by the Honorable Minister of FCT, and down the years, we've been growing from strength to strength. Our goal as an establishment is to ensure that every child is happy, because a happy child will make a happy home. Okay, so our discussion this afternoon will center on recalcitrant seizures. You'll be wondering, what is recalcitrant seizures? Recalcitrant seizures are also known as refractory seizures, also known as intractable seizures, also recently christened as drug-resistant seizures. So there are very stubborn seizures that we might find difficult to control in our practice. So we'll be looking at the underlying causes as well as the management modalities under the following outlines.
So by the end of this presentation, our aim is to be able to help each of us understand childhood seizures as a whole, know the different causes when we see a child that has a seizure, be able to guide any doctor on the baseline management of seizures. And at the end, when we see a child with a seizure, at the end of this presentation, our index suspicion for recalcitrant seizures should be increased. And we should be able to have the different management modalities for any recalcitrant seizure that presents to us in the hospital.
Okay, so we start off with a case vignette. Okay, this was a child that was rushed into our facility like 2 months ago with a focal onset seizure. The seizure started as on the right side of the body, uh, tonic extensions of the right upper and lower limbs with paresis of upward gaze and eyelid myoclonus. So that was how the seizure started. But along the line, it became secondarily generalized, involving both the right and the left side of the body, and was also prolonged, which necessitated their decision to rush the child down to our facility. This seizure had lasted for up to an hour before they came to our facility. Now, the other thing in the history, you can see from the picture that the child had a purple stain over the right side of the face. Let's see, the purple stain also had a giant melanocytic nevus covering the entire right arm. Then there's also extensive melanocytic nevus that cover the entire right lower limb. Then the right aspect of the trunk is sparing the right nipple area. Then the child also had hemihypertrophy. You can see that the right arm is quite bigger than this. The mid-arm circumference here was greater than the left. You can also see the lower limb, mid-thigh circumference was bigger, as well as the calf circumference. They were all more on the right when compared to the left. So the child had an associated loss of consciousness and post-ictal somnolence. You can see that the child at this point was sleeping. So that's, but when the child came 2 months later, we managed the child for some days on admission. We were able to abort the seizure after the use of up to 3 different anticonvulsants with no headway. So we eventually aborted the seizure and placed the child on the appropriate anticonvulsant based on the onset, the focal onset of the seizure. And this was a child 3 days ago when she came for follow-up, and she has been seizure-free for up to 2 months. You can still appreciate the hemihypertrophy, the right, if you compare the right to the left, the right upper lip, the left. Okay, so at this point, as is our custom, I want to ask us from the history presented, what do we think was the likely diagnosis, the likely cause of the child's seizures? Then what is the stepwise approach you take if this child had presented to you? Okay, so okay, so if you have the answers, just drop them on the Q&A section of the you can find at the upper part of the of your screen, the Q&A section. Just put the answers you think is appropriate for the questions. So while we wait for the answers, we'll continue with the presentation. Okay.
So, by way of introduction, when we talk about a seizure, so a seizure is the occurrence of signs and symptoms of any abnormal synchronous activity from the brain. And these symptoms or signs could be either motor, sensory, it could be visual, it could be psychic, it could be behavioral. So usually
Could
be autonomic as well. So when we say convulsions, they're usually they are the motor manifestations of a seizure. Doesn't mean a seizure as a whole. So epilepsy is a chronic disorder, and it is due to a predisposition of a child to have or anybody to have a seizure. And this in turn can affect the child or the person in from the cognitive aspect, the neurological aspect, social aspect of the child's life. Other aspects like the refractory seizure, like we mentioned, or recalcitrant or intractable seizures or drug-resistant seizures. They are seizures that are not being controlled by anticonvulsants. And this usually involves when you use either two or more anticonvulsants, either together or singularly, and there hasn't been seizure control. And about 1/3 of people that have epilepsy in general, it will eventually progress to a refractory seizure. So other types of seizures we have the febrile seizures, which usually present between 6 months to 6 years. And they are seen in children that have fever of 38 degrees or more. And when you go back to the history, there hasn't been history of any afebrile seizure prior to the onset of this seizure. There hasn't been any history of any infections, any other cause rather than it being due to the fever. Acute symptomatic seizures, on the other hand, occur due to an acute insult, either caused by a metabolic disturbance, electrolyte imbalance, and other causes.
So we had to come from that angle of defining these common causes of seizure, especially febrile seizure, because 60% of seizures in children is caused by acute febrile seizures, previously known as febrile convulsions. So febrile convulsions will just capture only the motor aspect of the seizures. So when you say acute febrile seizure, both the sensory, the autonomic, the behavioral, the psychic, and other manifestations of abnormal neuronal activity will, be represented. So about 30% of children who had, sorry, this should be who had a febrile seizure. That's those that had febrile seizure within the 6 months, between 6 months and 5 years of life, they end up having epilepsy later in life. And the ones that usually have this later epilepsy in later childhood or later in life are actually those ones that will have the complex febrile seizure, which we will come to. About 4 to 10% of children, generally in the general population, will have at least an episode of seizure, which can be febrile or afebrile. There are people that will tell you, I had convulsion as a baby, but since then it hasn't happened again. It's normal, it can happen. And this is usually seen in the first 16 years of life. So during childhood, you actually find that up to 10% of the general population may have had a seizure, during their childhood period.
So these are some of the causes of seizures in general. So the first one, like you mentioned, is the febrile seizures because they're the most common types we see. So it can also be caused by CNS infections like meningitis, encephalitis, meningoencephalitis, intracranial hemorrhage, drugs, encephalopathy, trauma, if there is head injury, hypoxia, hypoxic ischemic injury, like in children with birth asphyxia, they can actually have a seizure as well. Cerebral malformations, like we'll discuss later concerning our index
Like the index
case
case that
presentation.
presented will show you some of the imaging studies that we got from the child. Okay, so let's check if anybody has dropped any answer.
What did you call this?
Those hyperpigmented areas. Okay, so we'll be describing them, you know, tuberous sclerosis complex. Well, that's
Strong differential.
okay, one of the differentials. Please let's keep sending in the responses. Um, the hyperpigmented, okay, so can call them hyperpigmented patches. They are giant cell melanocytic navels. So when the macles are actually extensive like that, can have giant cell melanocytic navels. So there are portoine stains as well, the ones
On the face.
seen around the face. Okay, neurofibromatosis, interesting. Only one person is giving all the differentials. What happened to 99,
The other
98
95.
others now? Out of 90, okay, 100, only one person out of 100 is giving us the answers. Okay, so for drugs, nowadays there are a lot of things, a lot of materials our young children abuse. So some of these drugs, withdrawals, symptoms of the drugs can actually manifest as seizures, so that we know how to explore, try to unravel whatever is causing the seizures. Okay. 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 So for refractory seizures, no, traditionally, once you've used up to 3 anticonvulsants to manage a seizure disorder or epilepsy, and you don't make any, headway, traditionally would have said that such a seizure is recalcitrant or refractory or intractable. But recently, the International League Against Epilepsy, their task force that try to monitor international best practices, um, recommended that the term drug resistance be used to represent that category of epilepsies that 2 drugs were unable to control. Now, these 2 drugs, one must have been appropriately chosen, because there are drugs for focal onset seizures, there are drugs for bilateral onset seizures, and it must have been administered either singly as monotherapy or in combination. So if um, 2 drugs have been used, appropriately chosen medications have been used, anticonvulsants have been used, and whether as monotherapy or in combination is unable to help achieve seizure freedom, that seizure can comfortably be described as drug-resistant epilepsy, DRE. So any seizure at all, like the child that presented, had been, on 4 different anticonvulsants, had been on Phenobarb, had been on Epanutine, had been on diazepam at a point, and none of them was able to control the seizures before we had to, commence on the medication we use, carbamazepine, which is the ideal drug for focal onset seizure.
So it's important to note most causes of refractory seizures are structural. So these are just some of them, like the storage about various sclerosis, which somebody already mentioned.
Somebody has mentioned.
Scoliosis.
But somebody mentioned the neurofibromatosis. So neurofibromatosis, among the neurocutaneous syndromes, neurofibromatosis doesn't usually cause. You can have gliomas, around the acoustic neuromas and all that, which have to do with the hearing aspect. So the neurocutaneous syndrome that actually cause, the two that will cause recalcitrant seizures and Sturge-Weber and tuberous sclerosis. Somebody rightfully put tuberous sclerosis there, but Sturge-Weber, the child had Sturge-Weber. We'll see the findings on MRI and the EEG finding as well that made us arrive at that conclusion. So let's see more entries. This one we're giving the answer. So sorry, please, I missed the case presentation. I appreciate it. And so this slide. Okay. So the you will get the slides at the end of this presentation. To be sent to the email address that you registered with. So okay, somebody has gotten the diagnosis. Okay. So Samdi will send the slide to you. Okay, so we move on to the International League, the 2017 classification. Before now, when some of us were in medical school, there were other classifications, partial onset with secondary generalization, and generalized seizures, where they classified it into all those GTC, tonic, clonic, atonic, absence, and all that. That was the old school classification. This is the recent classification. So the reason why this classification is important is that if you don't know how the seizure started, like some of the people that saw this child, you will not know the best medication to give. The child presented to us with generalized seizure at the time, but we had to go back to get the history of how it started. That was how we knew the best drug to use, which was carbamazepine, instead of the pantene or the phenobarb they were given. So, and that has been able to give us a good seizure control, at least for the past 2 months. So for this classification, focal onset, there is focal aware, that's focal onset, and there is no loss of consciousness. Let me just use a term that will be able to identify it. There's also focal onset with impaired awareness. So this focal onset can be motor or non-motor. So all those sensory, autonomic, psychic, behavioral, these things that are focal will come under non-motor onset. That's focal, non-motor. Then, like the child that we presented, can also have focal to bilateral. But a child that hasn't achieved good muscle mass and all that may not have tonic clonic. For infants and younger children, it's either tonic, clonic, tonic, myoclonic, or that myoclonic can be focal myoclonic, can be multifocal myoclonic, can also be multifocal tonic. So because of the nature of the muscles are still not very strong. So, but for older children, can have focal to bilateral tonic. So for the generalized seizures, generalized onset or bilateral onset, you can have the motor or non-motor. The non-motor is what we call absence seizure, what we used to call absence seizure before. So when you have generalized non-motor, because the person might just be doing something and now start staring. After some time, now go back to what he or she was doing, continuing from where he or she stopped. So that one, there's no motor manifestation. But absence seizure, I must say, there's also the atypical one that has a motor component. You have eyelid myoclonus in atypical absence, as well as drop attack. You have loss of muscle tone in atypical absence. But that is where some people will fault this classification, but for the sake of the choice of medication, we need to know the onset of the seizure, whether it's focal, whether it's generalized, whether it's the one you don't know. Some of the epileptic syndromes, you can't really place them in any of these ones. You can't really know how it started. So this is the simplified recent classification by the International League Against Epilepsy. So we've talked about this. We've talked about this. Okay, so let's dwell a bit on this.
Yes, it's important to note this part because so febrile seizures, we have the simple and the complex. But for the sake of the presentation, the most important one we'd like to focus on is the complex. That one is focal. So the difference is the simple is more generalized, lasting for less than 15 minutes, and you usually have just one episode in 24 hours. But when you have a complex febrile seizure, it lasts for more than 15 minutes, and you can have more than one in 24 hours, and it's focal. And the reason why it's important is because complex seizures can actually progress to refractory and epilepsy seizures. Yes. So, and it's important to note that febrile seizures are diagnosis of exclusion. You have to diagnose all other causes of seizures, whether CNS infections, metabolic derangement, electrolyte derangement, or even non-febrile seizures, not caused by anything. Once you have that, you can't call it a febrile seizure anymore.
Okay, so for evaluation of seizures now, it's very important you get a history. We've already talked about the need for us to know the onset, how this seizure started. Was it one-sided? Was it involving both sides? What was the duration of the seizure? How many times was the frequency like? How many times does it occur in a day, maybe in a month, in 6 months, in a year? Associations like pre-seizure aura, post-ictal events like sleep, like confusion. All these things will actually help us know the semiology of the seizure. But most importantly, we need to know how the seizure started because the drug you use for focal onset seizure is different from the drug of choice for bilateral onset seizure. If you don't know how the seizure started and just throw in any anticonvulsant, you may be out for a very long walk. Like this child from neonatal, period was admitted for quite a while during the neonatal period for up to a month. Had seizures. The frequency reduced, but continued having the seizures till 22 months when they presented with a status seizure. So it's the frequency of these seizures can actually affect the child's development because at the time the child was not walking at 22 months because of the how frequent the seizures were. So, but coming to clinic for follow up 2 months later and walking into the consulting room was something of immense joy to the mother. And just try to imagine if somebody one of your clients or patients or guests, as you call them, comes to you in that kind of state, you'll be happy and also feel fulfilled as a practitioner. Now, the past history of seizures is important for you to actually understand how the control has been. Family history of epilepsy is important so that if you're dealing with some syndromic epilepsies, you'll be able to know what exactly is causing it. It's good to have video recordings of these seizures, seizure charts. If the parents come to the clinic with video recording, can also help you decipher what the nature of the seizure is. Because if you don't really know what the seizure is, you will not even know how to go about sampling. And the other thing is the eyewitness account is very, very important. At the time the seizure is happening, the caregiver may be so overwhelmed or scared or in a kind of shock to even recall how the whole event was. But a recording, a video recording or an eyewitness account of how this the semiology of the seizure was will go a long way in helping you know how to go about managing it. Examination, physical examination is important. You do general examination to know whether there is any, whether there is pallor, degree of dehydration. If the child has been passing this to possibly the child could have some electrolyte imbalance, dehydration, which you need to correct. Most times when there is electrolyte imbalance, it can be causing seizures, the metabolic cause of seizure, and you'll be trying to abort. Meanwhile, if you don't sort out that underlying electrolyte imbalance, it will not, the seizure will not stop. A child that has, hypoglycemia, for instance, you like continue giving all this, you can just give the ones benzodiazepines that will sedate the child. The child will be sleeping. You think that seizure has stopped, but subclinically, the seizures might still continue until that hypoglycemia is corrected. The same thing, applies to hypoxia. If you look at the appearance of the child and the child appears cyanosed, appears pale, it might point to the fact that the oxygen saturation, tissue oxygenation is poor. And if you don't correct that tissue oxygenation, the seizure will not stop. So, general systemic examination. General examination is important. Then focused neurologic examination, like our index had focal neurology, lateralizing signs. There was hypotonia on the right, where you had those hyperpigmented lesions. Then there was hypertonia over the left upper and lower limbs. There was also hyperreflexia on the left upper and lower limbs. So it's important that you do thorough neurologic examination. So that if there is lateralizing sign, it tells you that something must be impinging on the nerves on one side of the cerebral hemisphere, like we did in the child, and so that warranted the request for brain MRI that now showed some of the features you see in the subsequent slide.
Okay, so after your history and your examination, investigations are also very important. Like we mentioned, if a child has some electrolyte disturbances, so you need your baseline investigations, your electrolytes, urine creatinine, calcium, magnesium, a full blood count, malaria, parasites, you check your sugar and all these things. But then especially for index pregnancies, index case, imaging is also important because like we'll see in subsequent slides, the MRI that was done helped to give the diagnosis. And then there was also an EEG.
So let me talk a little about the EEG. Now, EEG, most times people send for EEG. Once EEG is done and it comes out normal, they say, child is fine. Now, there are some conditions that need to be met for you to even see something on EEG. Sleep deprivation. The child needs to stay awake from midnight till the following morning that the EEG will be done for you to see some characteristic epileptic tracing, epileptic form waves. Now, apart from that, photic stimulations, hyperventilations, there are other things that the technician needs to do for the child to increase the chances of even seeing something on the EEG. Now, a one-off EEG recording may not really pick up anything. So there's now these discussions around video EEG monitoring. You actually not just use a mobile EEG gadget. The child carries it around, or you can do for 24 hours, and any within this period, once there is any abnormal EEG recording within this period, it's picked up in the recording. By the time you play the recording throughout that period, you now see whether along the line there was any abnormality. And the video also tells you at the time that the abnormal recording was, picked, was there any physical manifestation, any maybe motor or autonomic or whatever manifestation that accompanied it. That way, you were able to, pick even some abnormal EEG tracing that ordinarily may have been missed with the normal outpatient booking and the EEG recording. Okay, so this is the brain MRI of the 22-month-old female that we presented. If you look at this slide, you agree with me that the usual sulci and gyri on the left side wasn't present on the right. And there's also thickening of the choroid plexus. So there was cortical atrophy on the right, the same side that those lesions, port wine stain, the hyperpigmented lesions were seen on the film. So this is another film that shows it. So the findings of cortical atrophy and mildly thickened choroid plexus in a child with port wine stain, hemihypertrophy, and other cutaneous episcleral macules and other hyperpigmented lesions on the skin, were in keeping with Sturge-Weber syndrome. So this child had a focal onset seizure because of the ipsilateral cortical atrophy that she had, and we placed on carbamazepine, which is the drug of choice for focal onset seizures. There are other drugs to use for carbamazepine. Most focal onset seizures do well on carbamazepine. So that's what we placed the child on. And from the point we placed the child on that carbamazepine till 2 months after, the child has not had any seizure and has been able to achieve the belated milestone that she hasn't been able to achieve, like walking. Child was not walking at the time we saw at 22 months and is currently walking. So let's see whether there are other entries. How do you classify a seizure that meets all the criteria? Febrile seizure, or the temperature is less than 38 degrees. Okay, so when you're looking at axillary temperature, the temperature we saw there is actually the core temperature. So axillary temperature is 0.5 degrees less than rectal temperature, and rectal temperature is 0.5 degrees less than the core temperature. So technically, if you're looking at a child that has fever now, that you've ruled out other causes of acute encephalopathies, ruled out metabolic imbalance, you ruled out hypoxia, hypoglycemia, CNS infection, and other possible causes of convulsion. You can now, by way of exclusion, say that the child had febrile seizure, febrile convulsion, if you like. Now, what actually causes the seizure? If you let's go a bit celestial now. Now, what causes the seizure is not really that temperature per se. It's the rate of rise or rate of fall. Now, if a child has a fever that rose rapidly within a short period, that rapid rise of temperature is what will, the brain will, want to respond to by throwing some seizures. Or a child has fever now, instead of using a tepid water to clean, you use cold water to bathe the child. If you force down the temperature, the child can still throw another fit. So let's just leave the temp. What we know is that there is fever in that child. You've ruled out other causes of acute encephalopathy. Then you've also looked at the duration of the seizure, how many times in 24 hours, and the nature of the seizure, whether it's generalized tonic-clonic, whether it's focal, whether the duration is less than or more than 15 minutes, and the number in 24 hours. So those are the things that you use to, classify whether it's, simple, febrile, or complex. Okay, so this is the representation of what the EEG of the child look like. So this is not the child's EEG anyways, but this is just a representation of what the child's EEG looks like. So let me not take us deep into some complexities of EEG reportage. This is a bipolar montage. So there's a way the electrodes are represented here. So this one, they try to put the ones on the left separate from the ones on the right. So here now you can see all these waves, what we call spikes here, that we are not here. So this is one side, it is like a focal onset seizure. You can see some of those things here, but this one is not like that. So at this point now, towards the end of this tracing, all of them now got involved. So this is what happened thereafter. So it's a focal onset to bilateral seizure. So it started from one side of the brain and now involved both sides. So that was the nature of seizure the index we presented had.
So, management of any child that has a seizure.
Seizure generally is okay. So it's an emergency. You have to follow the normal A, B, C, D, E of resuscitation. A, ensure that the airway is patent. Because if the airway is not patent, if there are secretions in the airway, those secretions can impair oxygen supply from the from the environment down to the lungs for ventilation, perfusion. So that can lead to hypoxia that will present as seizure. So the first thing you do is to check if the airway is not patent, suction, remove any secretion. If the child was eating food and the food got stuck and the child lost consciousness and started convulsing, carefully sweep and remove that. So that's the first thing. Secondly, ensure that the child is breathing. The child that is not breathing well, or is having sleep disordered breathing, or is having stridulous breathing, the oxygen supply can also be affected in that instance. So you also ensure that you clean the airway, like a child that has obstructive sleep apnea, for instance. CPAP can help splint the upper airway. Apart from the peak end expiratory pressure CPAP offers, there's also the peak inspiratory pressure that helps to splint the upper airway, that will ensure that oxygen gets to the lungs. Now, C, you secure IV access, collect sample, ensure that you check the blood sugar. If the blood sugar is low, you correct. You check for serum electrolyte and creatinine. If the sodium is low or high, it can cause seizures. If there is any of those abnormalities, give the appropriate fluid to correct it. Now, D, check for any deformity. If there is anything that is not normal, correct it. E is you expose, examine. Like the child, the index, if nobody looked at the if nobody looked at the child's okay, so if nobody looked at sorry, we're having some issues. Okay. So if nobody looked at the child's skin, like the index we presented, nobody would have noted those portoine stains, those hyperpigmented patches all over the skin. Nobody would have seen the episcleral markers, in the sclera, and there wouldn't have been any intuition to to request for a brain MRI. So it's important that we follow those ABCD of resuscitation. Monitor the vital signs. The vital signs, one of the reasons why this vital sign issue is important is if there is a raised intracranial pressure, for instance, there's cerebral edema, and cerebral edema causing the convulsions, there'll be um, these Cushing's triad. You have hypertension with bradycardia and irregular breathing. So if the blood pressure is not checked, if the pulse rate is not checked, you may not know that something like that is going on. So the seizure control is very, very important because the earlier the seizures are aborted, the better, to avoid the cytotoxic edema that can follow. The more those abnormal signals go on in the brain, the more there will be some harm, some injury, in the brain that might lead to cytotoxic edema, cerebral edema, and it will now be like a vicious cycle and all that. So for the control of the seizures, IV diazepam at 0.3 milligram per kg starts can be used. Rectal diazepam at 0.5 milligram per kg can be used. Remember, the rectal diazepam is not like there's a special tablet of rectal diazepam that you now start looking for. The normal vial of diazepam, just gets your syringe. The weight of the child times 0.5. Whatever it gives you, put in a syringe. Remove the needle and push it through the anus and hold the anus for like 2 to 3 minutes. That will help to abort the seizure. You can also use IM parathyroid. Like the index, we had to use IM parathyroid. How IM parathyroid is given is either 1 mil per year of life or 0.1 mil per kg. The child's weight was 14, and we had to give 1.4 mils. If we say the child is 1 year and we use only 1 mil, that may have not been very useful. IV midazolam or sublingual midazolam can be used. So if the seizures are not controlled, you can go on to use IV phenytoin at 5 milligram per kg starts, or you can increase it to like 10 milligram per kg start. But when you're giving, you put in a Soluset, let it run for like 30 minutes to 1 hour. If that fails, you can use phenobarbital. If if you're doing phenobarbital, please 5 milligram per kg starts. When you're unable to achieve within 10 minutes of using that, if you don't have a good control, you can do 10 milligram per kg. Remember, you put in a Soluset, let it run for like 30 minutes to 1 hour. Now, if you're doing in the books, you will see up to 20 milligram per kg. If you're doing 20 milligram per kg, try and be sure that you have an ambu bag present, because you might sedate the child and you won't be able to ventilate. The child may not be able to breathe again. Respiratory depression can happen. So the other, if that one fails, you can now do invite an anesthesiologist to take over the child's airway, and you can give propofol or thiopenta. Don't give propofol like Dr. What's that? Michael Jackson's doctor. I went to give propofol. in his house. Don't give propofol in somebody by the ward. Though. You have to ensure that the child is in ICU before that is done.
Okay. So we come to the main bulk of the presentation now. So
Okay, so for refractory seizures, now if a seizure, if you are unable to control seizures after the use of two anticonvulsants, appropriate anticonvulsants, whether in combination or single, there are a number of things you should do. If you follow this algorithm, it will guide you on what to do. First and foremostly, ensure that the dosage of the drug is appropriate. Check the weight of the child and multiply the weight by the dose and ensure that what you're giving is what it should be. So ensure that this drug is being given through the appropriate route. Ensure that the frequency of administration, there are plain anticonvulsant and the slow release formulation. The slow release formulations can be given 12 hourly, but the plain ones you have to give 3 to 4 times daily. So if somebody was on Epilin Chrono, for instance, or Tegretol CR, and you now start giving the plain Epilin or the plain Tegretol, there might be breakthrough seizures. So that breakthrough seizures might be as a result of the frequency that is not correct. Duration of the seizure is another thing you need to consider. If a child has an epilepsy seizure and you've placed on the appropriate anticonvulsant, there is a duration of time this drug should be given. If the drug is suddenly stopped, before the duration, depending on the type of seizure, some people give for 2 years, some people give for 3 to 5 years before stopping. Now, if the child has not gotten these drugs for the period of time, the duration of time it should be given, there could be very difficult to control seizure. And when you're stopping, you don't just stop it abruptly. You taper it down over a period of, for me, up to 3 months. You just gradually taper it down. Now, if you've checked all those things and you're doing the right thing, you can actually step up the dose of the medication to the safe maximum dose, one of the anticonvulsants at a time. Don't start, maybe you start Epilin, for instance, sodium valproate, and it's not stopping the seizure. Instead of escalating to the safe maximum dose, you now throw in Keppra and say there's still no seizure control. Now, the child might be taking two anticonvulsants suboptimally. That may not give you good seizure control. So you have to optimize one first. When you're done optimizing one, you can now add a second one. So if that fails, ketogenic diet is another modality. Not the keto. There was a time a number of people joined keto diet group where one of my friends that had a pot belly, the wife joined the group and was giving him achi. There's all this thing they used to take in soup. Was using it to mold the Gary for the young man and hunger. He called me one day and told me that hunger wants to finish him. So I had to counsel the wife that ketogenic diet doesn't mean that you now turn your husband to a vegetarian. So ketogenic diet means that you're giving a high fat diet, and the fat is not your chicken republic. It has to be medium chain fatty acids, and the food in our environment that you get this medium chain fatty acids from is coconut. So coconut, whether you deliver it as a coconut rice or whether you use it to make whatever, but that is the main thing in ketogenic diet, and the carbohydrates need to be low. And what the brain, apart from glucose, which can lead to all these neuronal misfiring. Ketones can also be used by the brain as well. But if somebody is fasting, for instance, your level of activity, your level of cognitive prowess is less than when you've eaten. So somehow this the ketone bodies that are sent to the brain as well will also help modulate the neuronal discharges that may be difficult to control. So that's how ketogenic diet helps. So if that doesn't help control this refractory or drug resistant epilepsies, you can offer electrical stimulation. Um, by the child's bedside, you can do vagal nerve stimulation by placing a cold towel on the forehead or massage the vagus nerve around the internal carotid. So those are that's one of the things you can do. You can also do responsive neurostimulation. That one is where it's available. You can do that. So if that fails, there's also the role of surgery. The lobectomy that was done, they used to offer before, where you remove the whole lobe. If there's temporal lobe epilepsy, you remove everything so that the seizure will stop. Remember, when you do that, other vital windows may be affected. The seat of emotions might actually, temporal lobe, where you have speech area and all that. You stop the seizure and the person is no longer talking. Doesn't make sense. So what they do nowadays is a multiple supplier resection. So you actually target those neurons that are misfiring and resect them. So that can help. So other modalities of management include deep brain stimulation for seizures that happen around the menstrual period, known as catamenial seizures. Hormonals can help. These other drugs, anticonvulsants, other measures may fail to control seizures, catamenial seizures. So, since estrogen is the hormone that plays a key role during the first phase of the menstrual cycle, when they are placed on progesterone, they do well. It's good control. Progesterone or acetazolamide can effectively control catamenial seizures. For those in Canada, some states, United States, where they've legalized cannabis. In fact, they now make it in a very presentable and appealing formulation. There's cannabinoid oils, which few drops, 1 ml can just help the person. Somebody that is having very difficult to control seizures. Seizures will stop. But that's for the people that it's acceptable where they reside or where they practice. If you go and give prescribed cannabis to a child having seizures and police catches you, I'm not responsible. Okay, so let's look at, I think we have other, okay, kindly go over the algorithm from phenytoin to phenobarb, especially the dosing. Okay. Baderinwa wants us to go through the algorithm. Okay, so different facilities, different centers have their different algorithm for management of status seizures. A status seizure, you don't have seizures that are prolonged, seizures that, for now, seizures that within the seizures that don't stop within 5 minutes. Because any seizure that doesn't stop within 5 minutes is unlikely to stop. So nowadays, the classification of status seizure is any seizure that has lasted more than 5 minutes. Gone are the days where somebody will present to you with seizures and you're checking your watch for the seizure to last up to 30 minutes so that you now shout Eureka that you made the diagnosis. So the more prolonged the seizure, the more the neurologic sequelae that might follow. So if a child presents to you with seizure, the first thing to do is to use either IV or rectal diazepam. IV diazepam is 0.3 milligram per kg starts. Rectal diazepam is 0.5 milligram per kg. You put in a syringe, remove the needle, and push the aperture of the other
The
end of the
plunger,
syringe through the anus and push it and hold the gluteal area together for 2 to 3 minutes. So if that fails, you can go over to IM paradehide, 1 ml per year of life or 0.1 ml per kg. There's also room for rectal paradehide, but the paradehide, don't give it raw like that into a child's anus. There will be synechia of that anal opening. So you dilute it in 1 in 3 dilution with olive oil, and the dose for rectal is 0.3 mils per kg. If you want to give rectal paradehide, 0.3 mils per kg in 1 in 3 dilutions of olive oil before you push, so it doesn't cause the rectal walls to stick together. So if that fails, you can now move over to IV phenytoin. Phenytoin is 5 milligram per kg. Remember, you put it in Soluset, let it run for 30 minutes. If that fails, IV phenobarbital. Phenobarbital, 5 milligram per kg, preferably. Maximum of 10 milligram per kg. Don't go up to 20 milligram per kg unless you have an ambu bag and people that will be ready to ventilate until the effect wears off. Remember, it's a long-acting anticonvulsant. If that fails, the next thing now is to invite an anesthesiologist to intubate, take over the child's respiration while you now give sodium thiopentone or propofol, and this should be done in ICU. Dr. B, I hope that answers your question. Okay. Okay, so
Okay. So some of the management challenges that can be faced when you're managing any child with recalcitrant seizures. The most common one we see is the financial burden on the family, because as you can imagine, it's going to probably be some time. The child will probably remain some time until we get seizure control. So the finances that the parents have to pay for the hospital stay, the doses, the drugs, some of these drugs are very expensive, especially if you are trying to use one that is most effective. And investigations, paying for other services like nursing care, the food they have to buy for the child, it's all very expensive and it can be a burden on the family. And another thing is the drugs themselves. Most preferably, we prefer to use the branded ones because we sometimes use the generic ones and you realize that there's no seizure control and you even reach the maximum dose. Like he gave the example of the long acting and then you change it to, so that can also be some of the challenges we face. And another thing is the psychosocial support. When you see a mother that has a child with those kind of seizures, they're usually down because they need a lot of support. Your child is going through this. Sometimes the father is not around because some of these parents, either the dad will abandon the child because of the burden, or the mom sometimes is not around. You see, it's the aunties, the relatives that are taking care of the child. So they also need that kind of support. The duration of the hospital stay, because like a case in next, I think she stayed for at least a week or so. So because we try to attain the seizure control. Another thing is the insurance. Some of them really don't cover for neurological cases. They cover for common diseases, like okay, infections, malaria, UTI, tonsillitis. But once you start bringing cases like seizures, Sturge Weber, they think it's a chronic disease really, so they don't cover for them. So it now rests on the parents to have to now start also thinking of ways to cover for their drugs and their treatment. The caregiver fatigue and burnout. You see these moms, by the time we've gone deep into the treatment, they're really tired. Sometimes you'll have to go home for a day or so and rest and bring somebody that will cover for them so that they can go and take care of themselves and come out because the way they look will also affect the child. So if you see a mom that is tired, the child will really not be because of the bond there. So it's important. That's also a challenge that we face. Then the chronicity of the condition, because like you said, they're actually chronic. Like sometimes before you even taper off the drugs, it can be 2 to 3 years. So you can just imagine for a caregiver to be going through that, coming to hospital visits, follow up. It's a lot.
From far places.
Yes.
No fuel.
Some even
long
travel
queue
from
and
outside
all
the
that,
states. So it's
actually a lot.
it's a lot.
Some may even decide not to come again
Yes.
because of all those
Back and forth.
problems and all that.
So these are just there are a few, there are a lot more, but these are just
it's not exhaustive. There are
yes.
a lot of other challenges, faced, while managing children with difficult to control seizure or drug resistant seizures. Let's say you place the child on a drug now, and the child has not used it for a month, but there is poor seizure control, and you need to maybe get a second line or have some add-ons. So this means more money and more expenditure, and most of them may be worried and will not want to carry on.
Yeah, I believe that's why during their follow-up they require a lot of counseling.
Yes, we really spend time. Neurology clinic most times. Why is prolonged is not that the condition you cannot diagnose or something. The psychosocial, the counseling, takes quite a while. Some will be crying. Some may even want to give up. Some will be blaming themselves. Maybe there was something they didn't do and all that. So these are things that you spend time to reassure them and make them realize that the control can be achieved. So somebody asked us to throw more light,
Loading and
maintenance dosing when using phenobarb.
So the person saying if you give 5 milligram, is it enough or do you need to give more?
Okay, so it's better to start with 5 milligram. So if the seizures don't stop after you give him 5 milligram, within 10 minutes of the administration of the 5 milligram per kg, you can give another 5 milligram per kg, but don't go beyond 10 milligram per kg because, okay, so for phenytoin, the side effect of phenytoin is hypotension or adverse effect, if you like, hypotension and arrhythmias. So the more you give and you don't have proper appropriate BP monitoring machine or ECG monitoring, the child might, through some arrhythmias, and while you're trying to stop the seizure, you just stop something more life-threatening than even the seizure. That's for phenytoin. So please don't do more than 10 milligram per kg and give like 10 minutes apart. When you give 5 milligram per kg, allow for like 10 minutes. If there's no control, you can do a second one. For phenobarb, the same 5 milligram per kg, you can repeat another 5 milligram per kg, but don't do more than that 10 milligram per kg, because if you do more than 10 milligram per kg up to 20 milligram per kg, there might actually be respiratory depression that will eventually make you have the need for ventilatory support. You bag the child until the child comes back, or you connect to a mechanical ventilator. So Given the high stakes in treating refractory epilepsy, should there be a standard protocol for the earlier consideration of surgical? Now, is it Dr. Chidera? Uh, when we are talking about surgical intervention, every modality of treatment has its own problem. Now, you're talking about craniectomy, you're opening the child's skull and you're looking for the neurons that are causing the abnormal seizures. It's just like and going to the university before doing primary one. This child we presented had Sturge-Weber syndrome, Sturge-Weber, tuberous sclerosis. These are some of the causes of very, stubborn drug-resistant seizures, and we're able to control it with Tegretol, that's carbamazepine. Why would we now offer surgery instead of, using the baseline treatment protocol? So I think it's best we start from the first step. Just use your baseline for focal onset seizure, use carbamazepine. For bilateral onset seizure, valproate for a child that is up to 2 years, phenobarb for a child that is still less than 2 years. At least let's just have that at the back of our mind. Let's leave these other surgical options for the ones that fail to respond to the lines of management we outlined. So in effect, there's no place for loading doses of this. Rather, it's just the maintenance. No. There is room for loading dose now. There is room for loading dose. Now, the maintenance dose of phenytoin and phenobarb is 5 milligram per kg per day in divided doses. You can either do 8 hourly or 12 hourly, 5 milligram per kg per day. So if you're giving it push, it's a loading dose. But personally, I prefer using a very low loading dose if it controls the seizure fine than using that 20 milligram per kg, which a number of times. So there has been some time that some of our colleagues use this and
The child just stopped
the outcome was not funny. So let's just, this one is based on practical experience. Let's just use the safe dose that will still give us the result we want to achieve. Please, the 1-in-3 dilution of formaldehyde with olive oil, is it 1 part and 3 parts olive oil?
or vice versa.
Okay, so is 1 part formaldehyde that's in 2, if you like, you say double dilution, that's 1 part and 2 part of olive oil. Let's say you want to give 1 ml of formaldehyde, you've calculated and it came up to 1 ml. Now get 2 ml of olive oil and add to the 1 ml of that formaldehyde. It's giving you 3 parts. There are 3 days, the formaldehyde is 1/3 of the whole formulation. So that's it's one part of this, 1 part of formaldehyde, 2 parts of olive oil if you're giving it rectally. Should anyone outside the pediatric neurologist be managing a seizure case after stabilizing? Okay, so for this one, I think, because if you're waiting for a child neurologist to come and abort the seizure, by the time they come, a lot of neurologic sequelae would have, happened. Either the child's milestone, already gained milestone, would have regressed. Some that were talking before would have lost that speech milestone, or there could have been one poor neurologic outcome or the other. Remember, some of the patients in question are coming from very far places. The longer the seizure, the more likely some of those neurologists in the next few slides you will see some of the complications of recalcitrant seizures that are left unaborted can lead to a number of things. So it's best at least leaving this discussion now. We should be able to know how to abort seizures when they present to us. Then by the time you must have stabilized them, you can now refer to pediatric neurologists for to unravel the underlying cause and place on the appropriate long-term anticonvulsant. Okay, I had a patient who had, we are reading the comments. Sorry, we'll continue with the presentation once we are done answering the questions and reading the comments. I had a patient who had generalized seizure at the age of 8, 9 years in the presence of no fever. The seizure was controlled with Tegretol within 6 months. Treatment continued for 3 years and tapered down for 3 months. He didn't have any relapse. My question is it likely to be the reason why he grew up to be short stature compared to his siblings who are 6 feet? He's now about 30 years. Okay, so to be difficult to, this is not, the information here is not all encompassing. He didn't tell us the family background, family history. There are some parts of the country that people from there are usually short stature. So we don't know the nature of the family this child came from, whether the parents are short. The parents of a short child will not give birth to a tall one, or maybe one of the parents might be short statured and
You followed
he took after maybe a chip of the old block.
Mhm.
Then another thing is the nutritional intake. Now, physical growth is actually a function of protein and calorie intake. If when the child was growing up, or when the man is 30 years old now, when he was younger, if his nutritional consumption, especially protein and energy, were not optimal, he may have not gotten to, he may not get to the, a very good adult height before the growth plates, fuse. So those are other things that we need to get from the history to know whether epilepsy is responsible or whether some other thing. And remember, this condition being a chronic one may also affect the child's nutritional intake. Maybe spending more time in the hospital and all that, the child may not actually get the maximal nutritional benefits. Okay, so what type and volume of fluid in a solo cell should fill? Okay, so just put them in normal saline. Put them in normal saline, just 10 to 20 mils of normal saline. Then put the drug and let it titrate for 30 minutes. That should be enough. That information is too limited to just such a
I think it's about the other question.
Okay, so quite a challenge. Okay, so I think we've handled all the, exhausted all the comments. So let's just continue.
Okay, so like we're mentioning when you're talking about not waiting for a neurologist to abort a seizure, these are some of the complications. Earlier, we mentioned raised ICP from repeated seizures and the Cushing triad. Another thing is if you notice, if a child convulses, let's even not say the child was eating, if a child convulses, sometimes they have a lot of secretions which can cause them to aspirate those secretions. So the child can have aspiration pneumonitis. Then when the child starts convulsing now and they're even eating, that's also another cause of the aspiration.
And sometimes there are very harmful practices. People trying to force
The child
force the child to take some things, maybe concussions and all that, while the seizure is happening. Now, the more they try to force that down the throat of a child that is unconscious, those chemicals, some of them are very, very, very harmful, can actually enter the wrong place and cause chemical pneumonitis as well.
So repeated seizure, the child will not be able to have enough oxygenation. So, and then physical injuries, sometimes when a child just is standing and then just falls down and convulses, or since, like a child that is between, let's say, 15, 16 years old, and they are riding a bike or something, and they start convulsing, that will cause road traffic accidents. If you are eating or you are close to fire or something and you just start convulsing, you don't really know what happened. The oil can pour on you, the fire. There are some cases like that. So, and another thing is, a seizure the more seizure you have, the more damage you have to your brain. So we've seen children in our clinic here with cerebral palsy, and from previous history, there was history of seizures, mental retardation. And subsequently, we've mentioned that children with seizures can progress to have the chronic condition of epilepsy, which can be lifelong.
Okay, so I think there's one more comment on the Q&A section. Parents are tall and male siblings agree up to. Okay. So we've mentioned other things now. So maybe when we have a very detailed history of what actually happened, we'll be able to say whether it's but Tegretol doesn't cause short stature. Is not a known side effect of Tegretol. Short stature is not unless maybe there's a new literature that gave such a deposition. So in conclusion, we've had quite a very interesting discussion this afternoon. In conclusion, childhood seizures can be complex, especially the drug-resistant ones. And there are a lot of issues that come with it. And because of some of these issues that might come with these difficult to control seizures, immediate medical attention is required. Because if a seizure happens and is allowed to continue, the neurologist, with all those complications we saw there, will be more life-threatening, might even lead to the demise of the child, as against what the seizure would have even caused. So immediate medical attention. We healthcare workers, when you see a child that is convulsing, please try and abort it. Aborting it is not rocket science, it's something you can do. And once you've aborted and you've stabilized, you can send to specialists or subspecialists to make a proper diagnosis and effectively manage it. The outcome depends on the age of onset, what is causing it, if there is family history or not of seizures, and the nature of the seizures. So I believe that rising from here, we should be able to handle even very difficult to control seizures and help our children with childhood convulsions.
The Limi Children's Hospital is a multi-specialty children's hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor. carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.